Welcome to the Hennepin County Medical Center training video on the use of ultrasound in gallbladder evaluation. Cholelithiasis is a prevalent disease in the United States. 20% of women and 8% of men above age 40 are estimated to have gallstones. The risk of developing symptoms from gallstones is low each year, but cumulative. 10% at 5 years, 15% at 10 years. Cholecystitis and biliary obstruction are important complications. Biliary colic generally presents as right upper quadrant pain or mid-epigastric pain. Classically, symptoms include pain that is postprandial, worse after fatty food consumption, 2 to 6 hours in duration, recurrent in the late evening or early morning hours, associated with nausea or vomiting, or radiates to the right shoulder. It can also present atypically with variations in location, duration, and radiation of pain. Symptoms often overlap with other intra-abdominal processes, such as peptic ulcer disease, gastroesophageal reflux disease, gastritis, or pancreatitis. Risk factors for biliary colic include diabetes, age over 40, pregnancy, obesity, and family history. Females are also at greater risk. Although biliary colic is primarily a clinical diagnosis, ultrasound can assist in the diagnosis by visualizing gallstones, evaluating for cholecystitis, and evaluating for biliary obstruction. This can be used to facilitate follow-up or determine if surgical consult is warranted immediately. It also decreases time in the emergency department. The patient should be positioned supine or in the left lateral decubitus position. If unable to get a good view in one position, try the other. Use the abdominal probe or curvilinear probe in a longitudinal position either at the right upper quadrant or starting in Morrison's view, also known as the hepatorenal view from the FAST exam, with the marker aimed cephalad. Starting at Morrison's view may help orient you to surrounding structures and help lead you to the gallbladder. Having the patient inhale deeply may bring the gallbladder into view as the diaphragm depresses the liver. If the gallbladder is still too cephalad to see adequately, consider moving the probe to an intracostal position at the 7th or 8th intercostal space, with the marker pointing towards the right axilla. In this position, the liver is used as an acoustic window to avoid bowel gas. However, this may limit your exam due to rib shadowing and will eliminate the sonographic Murphy's sign. Once the gallbladder is located, attempt to obtain a longitudinal view and a transverse view. Note that the longitudinal view of the gallbladder may not be in the longitudinal plane of the patient. Be sure the structure visualized is the gallbladder and not bowel or cyst by visualizing connection of the structure to the common bile duct. Be sure to scan through the entire gallbladder by tilting the probe. Gallstones in the gallbladder generally appear as hyperechoic structures with significant shadowing. If they are not impacted in the neck of the gallbladder, having the patient change position should show free movement of the gallstones. Gallstones range in size from small to golf ball size. Smaller stones are more likely to cause symptoms by becoming obstructions. Polyps and valves of Heister may be misidentified as gallstones. Gallstones that are impacted in the neck may be missed. A structure in the gallbladder neck that casts a shadow needs to be thoroughly evaluated to determine if it is a stone or an incidental finding, such as bowel gas or a valve. Visualizing a gallstone does not necessarily mean that the patient's symptoms are being caused by biliary colic. The findings in cholecystitis include thickened anterior wall greater than 4 millimeters, pericholecystic fluid, and/or a transverse diameter greater than 5 centimeters. Some bacteria will cause an emphysematous wall, necessitating immediate surgical intervention. Pushing on the probe while the gallbladder is centered in view may elicit an exacerbation of the patient's pain. This is known as a sonographic Murphy's sign. Finding sludge in the gallbladder is common, although nonspecific. Locating and evaluating the common bile duct can be technically challenging. Following the gallbladder down towards the neck, attempt to visualize the portal triad by gradually rotating the probe. A transverse view will appear as the Mickey Mouse sign. The large circle is the portal vein. The two smaller circles are the hepatic artery and the common bile duct. A longitudinal view will show the portal vein with the common bile duct running anterior. In either view, using color Doppler will help identify which structure is a blood vessel. A duct greater than 0.6 centimeters for a patient at age 60 is indicative of obstruction. Note that if a patient has had biliary manipulation, such as ERCP, duct size is not indicative of pathology. Ultrasound is one tool in the evaluation of the patient with suspected biliary pathology. It should be used in conjunction with the physical exam and laboratory testing to help establish etiology of abdominal pain. The quality and reliability of biliary ultrasonography is dependent on the operator's experience, but with practice can become a valuable and time-saving tool in the evaluation of biliary disease.